Welcome to the CRNA School Prep Academy podcast. I am your guest host, David Warren, and today we are going to talk about what a day in the life is like as a nurse anesthesia resident completing my first clinical rotation. For those of you who are new to the show, welcome. Thank you for listening. And for those of you who are repeat listeners, welcome back. We appreciate you as well. A special shout out to Jenny for welcoming me on as a CSPA podcast guest host. My background is quite a bit different than probably anyone you are going to run across. So I've been an emergency nurse practitioner for about 8 years prior to attending CRNA school. I'm in a front-loaded DNAP CRNA program out on the West Coast, and I am currently halfway through my CRNA school journey. I finished my didactic phase in March of 2023. I've been in that was in that for about 15 months, and then started clinical rotations in April of 2023 and just finished that a few weeks ago. I just started my second clinical rotation. But I want to talk to you today about what a day in the life is like as a first rotation nurse anesthesia resident. So to give you a little bit of background at my clinical site, I was at a level 2 trauma center and I had a really good experience. I will just start out by saying that. It was a really good experience for a first rotation student. I feel like I got exactly what I needed out of that rotation for a first rotation student. And so I found out where I was going to go for my first clinical rotation to a different state, by the way, about 3 months before I had to be there for my actual clinical rotation. So I found out about 3 months before the rotation started as to where I would be. And that allowed me time to find housing and et cetera, all the things that come with that, and plan travel, time off, all of those things. And so my schedule was Monday through Thursday, which was amazing. And we basically just ran the room, whatever time the room started, 7, 7:30, 8 o'clock until we were done. Sometimes that was 2 o'clock in the afternoon. And sometimes that was like 6 o'clock at night. It really just depended on when the room was like finished as to when we would leave. And so, and these are all things are going to vary based on what clinical site you're at. Maybe in your program or maybe the program you're looking at, you don't have to travel for clinicals. And so that's something to look into. Like for my program, I know that I'm going to have to travel for clinicals, and that's just a given. And I'm okay with that. And then the schedule and the types of things you do at each site are going to vary by each site. And so I feel like this place that I went was really good for a first rotation because we got a lot of generals, a lot of general surgery, a lot of ortho, and a few pediatric patients. So a good place to get like a good solid foundation. And so after I found out where I was going, I secured housing. I stayed at an Airbnb, which was, 15, 20 minutes from the hospital. Was great. Like, loved it. A good place. And whenever I met the clinical coordinator for that particular clinical site, we went over the expectations. And so basically the clinical coordinator sent out an email to me, and it was just like a one-page document that really detailed what the experience was supposed to be about, what we needed to do, what was expected of us, and things of that nature. And so for this particular clinical rotation, I was there for 3 months, and there were going to be exams that I had to take at this clinical site, which was interesting. There were pharmacology exams and care plans that were due. And so the exams were on just common drugs that we had to, obviously we have to know as nurse anesthesia residents and ultimately as CRNAs, common induction drugs. So things like fentanyl, propofol, and then neuromuscular blockers like succinylcholine, ROC, VEC, and then I think remifentanil, sufentanil, alfentanil. Those were in the opioid test day or whatever it was. And then we did like ketamine, dexmedetomidine, and I think that was it. I think those were the main drugs that we covered. And so the exams were fair, I think. It really wasn't an exam. It was like we would meet with the clinical coordinator, and he would give us a blank sheet of paper and say, write down everything you know about X, Y, and Z drug. Oh, we did the volatile anesthetics as well. So sevoflurane, isoflurane, desflurane. And he was like, just write down everything you know about whatever drug it was that day, or whatever class of drugs or drugs that we covered that particular day. Things like the dose, the onset, the duration, the metabolism, like all those things that we learn in CRNA school. And we met once a week. And so over the course of 12 weeks, we met once a week and discussed like a drug, and we would go through and write down all of the things that we knew about the drug, and then we would just talk through it verbally. If there were other students there, I was mainly the only student at this site. There were occasionally some other students from other programs. We would all sit together and just discuss like amongst ourselves what the common things about those drugs. And then after, we would also discuss like things that you may see in clinical practice that you don't really learn about in the textbook, or things that are in the textbook that maybe aren't super applicable in clinical practice. And so it was cool to like learn it for the, obviously the first time in CRNA school in the didactic phase, and then in clinical to actually go over it as we're using it day in and day out. And so that was pretty cool. When I first got that email with all of those expectations, and I saw there were exams and care plans and that, and I was like, oh no, this is going to be a disaster. But it ended up working out really well. And it was a great rotation. People were super nice, very understanding that it was my first rotation. So I feel like in that regard, it was great. The expectations were all very reasonable. And so that's kind of the layout of what, outside of the obviously showing up and doing anesthesia, outside of that, that's what that looks like. The care plans were much similar, except it wasn't necessarily a patient-specific care plan. It was more disease-specific. And so we had to do a care plan for like a COPD patient, and what kind of anesthesia implications do you watch out for with COPD? And then one for diabetes, what kind of anesthesia implications do you watch out for in patients with diabetes? And one was sepsis, I think. And so there were like, I don't know, and there weren't a full 12 care plans that we had to do. I think there were like 7 care plans, but it was all applicable. It was all things that, we would see on like a day-to-day basis of caring for anesthesia or caring for patients that were undergoing anesthesia and what those implications were. So outside of the clinical arena and actually providing anesthesia, we had to do those things as well. So the pharmacology exams and the care plans, still great. Like I'm not knocking on it. It was interesting when I first started to think I'm going to be going back to exams and more care plans, but it actually worked out well because that really solidified that knowledge that I already had in my head. It really solidified it when I could talk it out with somebody and actually see it in clinical practice. So that's what the outside clinical duties looked like. Now, day-to-day life, I just kind of want to take you through a day and share with you what that was like. So I would usually find out the night before what assignment I would have. And so the clinical coordinator would text me and be like, okay, you're going to be in such and such a room tomorrow with whoever, X, Y, and Z CRNA. And so I would text the CRNA the night before and be like, hey, so-and-so, I'm with you tomorrow. And they made sure I had access to their app. They had a particular app on the iPhone or Android, whatever it was, that you could log into. And you could see like basically the OR track board for that next day. And so you could see what cases you were slotted to do. Now, I did not have access to patient-specific information the night before. And so I couldn't really look up my patients. I did have information, like I had their age and their gender, and then I had information about the surgery, like whatever surgery it was. If it was a lap chole or a lap appy or a colostomy takedown, whatever the surgery was, like that would be listed there as well. And so I would usually the night before like browse through some of my anesthesia textbooks and like look up the surgical procedure just to kind of get familiar with it. And after a while, if you're doing general surgery, you're going to be doing some of the same procedures over and over. So, and that was another thing for this first rotation, the clinical coordinator was like, I want to put you just in general surgery for the first like 6 weeks, just so you can get used to the anesthesia machine, being in the OR, getting intubations, like all of the things. And so I had some good consistency for 6 weeks, which was amazing because at the end of the 6 weeks, I was like, okay, this is good. Like I can do this. It's not like I was jumping from all these different cases day one. In some places you're going to go, it's going to be like that. Like you may start out doing pediatric cases and you'll jump to OB and then you'll jump to hearts, and you may not get that consistency, but that's why I really appreciate this as a first rotation, or appreciated this as a first rotation, because I got really good consistency from day one for like 6 weeks straight, doing a lot of general surgery, like urology, GYN, robot cases, and then just strict general surgery, like hernias, choles, appies, that sort of thing. So I found it very helpful to just be doing that day in and day out, because you're going to get a tube with everyone. You're going to push induction drugs. You're going to paralyze. You're going to reverse. Like you're going to do all the things. And so it's really good to get your flow down. on your first rotation, just getting familiar with the OR and familiar with everything when you're in a familiar or you're in a like repeat environment over a course of a few weeks. So I really appreciated that. Okay, back to what I was saying. So I would find out the night before and I would look up the patient, not just the patient, but I would look up the procedure and see if there's anything that I needed to know that was anesthesia specific about that procedure. Like if you're doing a laparoscopic case, obviously, well, maybe not too obvious, but initial abdominal insufflation with either a trocar or a varus needle, that's kind of the most that's the area where complications are most prone to happen is initial abdominal insufflation. So you can have like a venous air embolism, you can get the significant parasympathetic response or a vagal response where with insufflation they go like very bradycardic and hypotensive. So that's like things like that. That's the kind of things that I would look out for when I'm reading over the procedure the night before. Like, are there any anesthesia specific things that I need to watch out for in this case? And so after doing general surgery for 6 weeks, like a lot of the same cases started to reappear. And so I got pretty consistent with knowing kind of what to expect and where. And still to this day now, like if there's a new procedure, I'll just take a look at it the night before and see if there's anything that I need to know, or if I remember anything, from my didactic training, if there's any anesthesia specific implications for a procedure that I need to look out for. And so that's kind of what I would do the night before. And then I would arrive to the hospital the next day, usually about an hour before my procedure or my surgery was scheduled to start. So if I had a 7:30 start, I was usually there by like 6:15, 6:30. And that would give me time when I like rolled in the building, go to the OR, get changed into scrubs. And then I would go to pre-op and I would pre-op my first patient. And so this particular site was an ACT site or an anesthesia care team site. So there were physician anesthesiologists who were supervising the CRNAs, and the supervision was very loose because half the time they weren't present, or I say they weren't present. They were there if needed, but it's not like they were in the room every time we were doing something. There were so many times that we did cases that like the anesthesiologist was not around, which is fine. They were there if we needed them. Like the CRNA could say, hey, I can call up so-and-so and, they'll show up. However, there were some of the anesthesiologists who knew that I was a first rotation student and who would come in on induction on like every patient. And this was very dependent on the particular provider. And they would teach me things. They would, give me tips and tricks as I'm like inducing and intubating. And so it really depended on the provider as to who would show up there, as far as the anesthesiologist, who would show up in the room and help out with the procedure. Or help out with the anesthesia, not the procedure. They're not doing the procedure. So I would get to the OR, change into scrubs, go pre-op my first patient, and I would kind of go through just a typical pre-op. And this takes some getting used to for sure, because as a nurse practitioner, I did plenty of like patient interviews, HPIs, exams, and then come up with an assessment and plan. Like that's bread and butter for a nurse practitioner working really in any area. But as a CRNA student, it is a little different, like to go through an anesthesia preoperative assessment. And so that really entails, and this is obviously not the format or the forum for going over an anesthesia preoperative assessment, but to get the basic idea, you want to kind of hit the major body systems and find out if they have any medical problems. So for like airway, we would ask, do you have any history of asthma or COPD, or do you smoke? Do you have sleep apnea? Do you wear a CPAP at night? Do you have any heart problems? Do you ever had a heart attack? Do you have any heart valve issues, weird heart rhythms? Ever had any stents? Can you walk? How do you get around? Can you walk a flight of stairs? Can you walk outside? Like things like that. And we would go through each body system and ask those pertinent questions, and then kind of tailor our anesthetic plan to that preoperative assessment. And so when I would get there, sometimes the CRNA would be like, oh, I'll go with you and just listen. And then some of the times they were like, no, just go do the pre-op and, I'll come behind you and ask if there's any questions or whatever and sign the consent. And so that's kind of how things would go. It was really dependent on what provider I was working with as to whether or not they would come in with me and do the preoperative assessment or just come behind me and, follow up with the patient and ask if there were any questions. And so that's kind of how that went. And then I would, after talking to the patient, figuring out, if they had any medical problems, if there's any anesthesia implications for those medical problems, or if I need to alter my plan in any way, then I would come up with a plan and determine, okay, I'm going to do a General anesthetic, we're going to use an ET tube. We're going to induce with X, Y, and Z drugs. Maintenance phase, we're going to use this gas, or we're going to do a TIVA, or we're going to do these regional blocks. And then emergence and extubation, we're going to give these meds. We're going to wake up deep, or we're going to wake up. We're going to wake up all the way awake, and then we'll extubate the patient, take them to the PACU. So that's kind of how I would go through my plan. I would really formulate just a plan in my head, and it's not something that I would take an inordinate amount of time to do. I would literally go see the patient, look at the pre-op, and then determine the plan within the next few minutes about what I want to do for that patient. And then I would go talk to the CRNA and be like, okay, this patient has X, Y, and Z. Like, here's my plan. I want to do this, this, and this. And usually the CRNA would have some follow-up questions about like, okay, well, what if you did this? Or would you want to do this? Or have you ever tried this? Or would there be any problems with doing this? And so we would just talk through a plan, get a plan together. I would then go to the room and get the room set up. And so that is variable depending on what surgery you're doing and where you're at. So we're just going to take like a normal general endotracheal anesthesia case, and I'll kind of walk through how it's set up for that case. So when I would get into the room, I use the mnemonic SAMTIDE, so SAMMTIDE. So S stands for suction. So I would always make sure I had my suction on and ready to go, especially during induction, because if you don't want to like go to intubate the patient and get your view and there's just goobers everywhere. So have your suction ready, make sure suction's on. Airway, make sure you have airway equipment available. And this is part of like doing that preoperative assessment, doing an airway assessment on the patient, and then determining like what's the patient's Mallampati score, go through like the limit assessment, and then determine, is this going to be, or is this person a candidate for an RSI, or should we just do a normal induction? And then what kind of airway equipment am I going to use? Do they need a glide scope, or am I going to DL this person? And then just kind of have plan B, C, and D, and E in the back of your head. Like if plan A fails, if I'm DLing with a Miller 2 and I can't get a view, like what am I going to do next? What are the next steps? And that kind of really goes down the like difficult airway algorithm, which obviously is not the talk for that, but just again, big, broad 30,000 foot view, have multiple plans for what you want to do for your airway. Also includes getting a tube out, making sure the cuff works, either put a stylet in it or go no stylet, whichever you prefer, and then have an oral airway out ready to go, a tongue blade, and then know where like your adjuncts are. So know where your bougie is, know where your LMAs are, know where the glide scope is, know where your fiber optic is. I got to use a fiber optic scope 3 times. Super interesting, very challenging. I just did an asleep fiber optic on patients just to practice, but know where that's at. And I would encourage you, if you're in CRNA school or if you're a student, like just ask, be like, hey, I want to try a fiber optic on this person. We don't have to do a wake fiber optic, but we can put them to sleep like we normally do, and then just use a fiber optic instead of doing DL or glide scope. So that's the airway equipment. The first M is either for machine or monitor, whichever one you want to choose first. So we'll go with machine first. Make sure your machine is on and checked. A lot of the machines now do self-checks. You'll just have to initiate the self-check. Make sure your circuit is like ready to go. A mask is there. Your vaporizers are filled and ready to go. All those things. Do like a high pressure test. And then the other M is for monitors. So make sure monitors are like in the room. Make sure you have a pulse ox, blood pressure cuff, cardiac monitor, and then temperature. If it's like a longer case, like we would use an esophageal temp probe, or we'd use a skin temp, whatever. And then a bear hugger kind of goes under, not necessarily monitors, but I usually put it under there because of temperature. So make sure you have a bear hugger, either an upper body or lower body, depending on what surgery, where on the body you're doing the surgery. T is for tape. So have tape for the eyes. So after you push your Preop and your rock or Preop or whatever, if you do them right back to back, tape the eyes down. And then you want to have tape for the ET tube. I usually use paper tape for the eyes, and then either the like orange ET tube tape or the like clear tape, whichever one you have available. I usually just grab whatever's there. I is for IV. So make sure you have a working IV on your patient. Preop should take care of that. If not, get an IV started. And then make sure you have 2 IV poles. There should be 2 IV poles in the room, and little clips so you can hang the drape when the drapes go up. And then drugs, make sure you have the drugs that you would need. So for standard induction, you can use fentanyl to block the sympathetic response and to block surgical stimulus to pain. You can also use esmolol to block that sympathetic response. And then propofol for induction, or ketamine, or etomidate. There's just a million things you could use, or a million different combinations that you can use, but have those induction drugs ready to go, your neuromuscular blocker. So if you're going to suck the patient, have sucks drawn up and ready, or rock. I will say this, if you're doing an LMA, I kind of found it's not the hard way. If the LMA like doesn't seat and you can't get good tidal volumes, like the patient starts desatting, pull the LMA out, you try it again, try to, obviously mask the patient, bag the patient back up, but you're going to need to jump to a tube. So if I'm doing an LMA, I always have an ET tube and a blade like out and ready to go. And I have a vial of sucks sitting on top of the machine with a 10 cc syringe. So if I'm in that situation, nobody's having to go drag, go pull through the anesthesia cart to pull drugs, like everything's sitting right there, pull the sucks, push it, and you're good to go. So just tips for me. I'm only a second year SRN or second year nurse anesthesia resident. So that's my tip of the day though. Have sucks in an airway ready to go if you're using an LMA. So neuromuscular blockers, have those ready to go. If you're doing like a general surgery case and you need paralysis, have extra paralysis ready to go. And so have extra rock or have some VEC or have something. If you use sucks, especially have some longer acting stuff there that you can get on board as well if you need paralysis. If you don't need paralysis, then you don't need paralysis. But if you need paralysis, then definitely have that extra available. And then have your reversals and your like multimodals type stuff ready to go, and antiemetics, so Zofran, Decadron, multimodal like Tylenol, Toradol, ketamine, dexmedetomidine, those things. And then have your reversals ready. So Sugamidex is the standard of care now. So have Sugamidex ready, or have your Neoglyco ready to go as well. Whenever you're ready to reverse. And then for your emergency drugs, I always mix up a bag of Neo at the beginning of the day, have Neo ready to go. Sometimes I find if I'm just like pushing Neo like all throughout the case for whatever reason, like it's easier just to have a pump and a drip. Like start a Neo drip, you're going to save yourself going over to the IV and giving 50 to 200 of Neo every few minutes. Start the drip. It's very easy. And then I always have ephedrine ready to go as well. So the thing with like neo and ephedrine, you have to watch the heart rate. Obviously, you'll get the reflex bradycardia with neosynephrine. However, I and others, you can give like 0.2 to 0.4 of glyco to treat the heart rate and then give neo, and that's kind of a way around it. Or you can just treat with ephedrine, which is direct and indirect acting. So you get the blood pressure up either way, but have those emergency drugs ready. And then it really depends on, I guess, who you're working with. At my first site, that was really the only emergency drugs I had ready to go were my pressors. So I would always mix up a bag of Neo. I wouldn't always mix up ephedrine, but I knew where it was at and it was ready to go. Sucks was out and ready, but I didn't draw up anything else. So I didn't draw up atropine, didn't draw up epi, like didn't do any of that, but knew where everything was just in case. And that was another thing. So after I like got in the OR for the first day, like I just went through everything, went through the drawer, went through the machine, like got familiar with everything that was in the room, where everything was. So that's the drugs. E is for everything else. So anything else you might need. We did a lot of TAP blocks and QL blocks for our general surgery patients. So have an ultrasound in the room, have your local drawn up with your needle attached, to do the nerve block, have a nerve stimulator if you're using neuromuscular blockers. Not everybody uses a nerve stimulator, but it's good to have one there, to before you pull that ET tube and you paralyzed and you document that you've got 4 twitches back. So it's really a personal preference thing, I feel like, for whatever CRNA you're working with, if they want that or not. But it's always things you can ask ahead of time. So after I did my SAM tide, got my room set up, drugs laid out, I would make sure everything's ready to go before the patient rolls back. So I would uncap my syringes, lay everything out like I needed, put the airway there, the oral airway. And then when the patient rolls in, I would, move the IV bag over from the bed to the pole in the OR, get the patient scooted over, get a blood pressure cuff hooked up, cycle the blood pressure, hook up pulse ox, and then cardiac monitors, get that initial set of vital signs while I'm pre-oxygenating. When that first blood pressure rings up, then you can start your induction. Your blood pressure's fine. You've pre-oxygenated for, 5 minutes or so, or some deep breaths to get your end-tidal O2 up to, 60, 80%, depending on the patient. And then push your induction drugs after you've induced, and then intubate the patient, tape the tube. And then after I've taped the tube, I would, intubate, confirm placement. So listen to bilateral breath sounds. You have misting in the tube. You have positive end-tidal for a few breaths. Inflate the cuff before you check placement. Obviously, I'm like jumping ahead here. So intubate, check placement. Intubate, inflate the cuff, check placement, and then tape the tube. After that, turn gas on, turn the vent on. That's something I feel like everybody forgets, every now and then, is you'll leave the patient on manual or spontaneous and you look over and they're like not moving they're not breathing, obviously, because they're still paralyzed. So turn the vent on, like very first basic step, and then titrate your gas to, to whatever it needs to be. And then after that, I would put the bear hugger on the patient, give antibiotics, give antiemetics, start my multimodals, and then do a block. If we needed to do a block, we would do a tap block or a QL block if it's a general surgery day. And then going through the case, we would just monitor the patient and then treat as necessary, treat blood pressure, whatever we needed to do in that maintenance phase of anesthesia. And then waking up was kind of much of the same. We would determine what the plan for wake up was. So if we're going to do a deep extubation, we would want to get the patient back breathing where we could pull the tube, was the end goal. And so after the procedure or after the surgery is over, I would go up to the head of the bed, suction the airway really well, put in an oral airway, and then try to build the CO2, because your drive to breathe is CO2, right? So I would turn my respiratory rate down quite a bit, to turn the tidal volume down, to really build their end tidal CO2 up so they would have that drive to breathe. And then once I know they're like closing fascia or they're like closing up, then I would reverse with Sugammadex. And at that point, turn the patient on pressure support. And I would make sure I have, if I'm doing a deep extubation, make sure I have a MAC of gas on, or 1.5 MAC. It depends on who I was working with. Usually most people were good with a MAC. There were a few people that were like, no, you need to have like 1.5 MAC to pull deep. So again, depends on who you're working with. As long as the patient, you're like wiggling the tube and the patient's not coughing or bucking, then they're deep enough to be deeply extubated. And that's going to vary patient to patient. And so I would, after reversing, they're on pressure support, let them work their way down on pressure support, usually start at 10 with a trigger of 2, PEEP of 5, and then work their, if they're not breathing very well, work the trigger down or work the pressure up, whatever they needed. If they're taking these big, giant 900 tidal volume breaths, they're not going to breathe frequently. So drop their pressure down, or even just put them on spontaneous, put them on the bag and let them breathe. The tidal volumes will start very small, like 60 to 80 tidal volumes, and then slowly build up over time. And they'll get to 200 or 300 tidal volumes within a pretty short amount of time. The only thing you run into with trying to do deep extubations is sometimes the patient just won't get back breathing, and in which case you have to either make the decision, is the patient fully reversed, first of all? So check your twitches. Did you give Sugammadex or Neoglyco? If they are fully reversed, then you have to make a decision. Am I going to continue to wait for the patient to breathe, or do I want to just wake them up? And so that's a decision you have to make. So thankfully, most of the patients that I had that I deep extubated, they breathed fine. And so eventually you work them onto the bag. Once they're breathing on manual or spontaneous ventilation, taking good tidal volumes, then they're ready to be extubated. You're at a MAC of gas, their vital signs are stable. I would pull the tape off their eyes, suction again, an oral airway is in. So once I pull the tube, they have something holding their soft tissues open so they don't obstruct. And then I would cut the gas right as we're about to pull the tube. And they go on 100% FiO2 right before we suction and put the oral airway in. We would turn them to 100% FiO2. So they have some reserve. After that, cut the gas, turn the flows up to 10, and then unhook my circuit, hook it up to the mask, and then pull the ET tube, and then put the mask on the patient. Make sure they're breathing, make sure they're moving. And a few things you have to worry about. So like a laryngospasm is kind of the most common thing. Again, not the place or the time to talk, or it is the place to talk about it, not the time to talk about it right now, but you can have a laryngospasm. So to treat that, you can do positive pressure ventilation or Larson's maneuver. Those are kind of the two most common things. So as soon as you put the mask on the patient, make sure you see fogging, look at your machine, make sure you see end tidal. And then, if they're not breathing, bag them, assist the patient until they can start breathing. Because if they're breathing with the tube in, they should be breathing with the mask on. It may take them a moment, but they should start back breathing. And then pull the mask off, put their face mask on, make sure you have fogging or misting. Sometimes you have to tilt their head to the side, one side or the other. If they're just laying straight ahead like this, they might obstruct. But, if you tilt their head to the right or to the left, then they will usually start fogging. After that, the stretcher comes in, you move the patient over, and then off to PACU you go. And then we would kind of do the same thing. After we got to PACU, we would get the patient hooked up to the monitors in PACU, get a set of vital signs in PACU, document that, and then give report. And so report would look something like this. We would say, usually the OR nurse would be like, okay, this is such and such patient. They had XY, a laparoscopic cholecystectomy. They have 4 incisions, and then the nurses would look at the incisions, and then we, the anesthesia provider, would give our report. And so that would be something like, this is an otherwise healthy patient, no past medical history. She was a general ET tube, easy mask, easy tube, paralyzed and reversed with Sugamidex. She got 100 of fentanyl. She got some Presidex and some ketamine, gram of Tylenol, 15 of Toradol, and you would usually say the times at what you gave. And then she got a liter of crystalloid, 20 EBL, no Foley, no urine. Any questions? So that's kind of what a simplified version of a report would look like. And, obviously if there's something pertinent that happened in the procedure, then you would mention that. Or if there's some weird, crazy medical history, you would mention that as well. But otherwise, that's kind of what report would look like. And then we would also talk about regional bilateral TAP blocks or bilateral QL blocks, whatever it was. So that's kind of what, from start to finish, the like first case would look like. And then after leaving PACU, we would go right back to pre-op, see the next patient. If the next patient hadn't been pre-opt, I would go through that same thing, go through all those questions again, come up with a plan, and then go to the OR, quickly get things set up. Or sometimes I would set up for the next case in the first case. So like after the first case gets started and we're in that maintenance phase, then I would get things set up for the next case, get drugs drawn up, get airway equipment laid out. So by the time I went to go see the patient, I would come back in the room, just lay everything out, and it's good to go there. So that's kind of what a day in the life looks like for a first or a second year nurse anesthesia resident completing my first clinical rotation. That's an example of like a general surgery day. Now, at this particular rotation, I did a lot of general surgery. I did a lot of ortho and then some pediatrics. And that was kind of the mainstay of that rotation. And I feel like it was a very good first rotation because we had those exams that I talked about. We had those care plans. We also had really good support. Like everybody was super nice, very welcoming, like very willing to teach. They wanted to teach. And the CRNAs and the physician anesthesiologists wanted to teach. They wanted to be there. It was an overall like welcoming, good environment, and I had a really good experience. So that's kind of what my first rotation was like and what a day in the life was like, kind of what day-to-day things I did in that rotation. Thank you so much for watching. I hope to bring you more content in the future. My plan is to bring you experiential content like this, but also to bring you some science-based content on like physiology and pharmacology and that sort of thing as well. So if you found this particular episode helpful, please comment below. Let us know what you think of it. If you have any questions, feel free to reach out to me. Thank you for watching, and I'll see you next time.